Hi, welcome to another session, and I'm going to take today you through with the recent advances in management of heart failure. So this topic has been something that is close to everybody in real day practice and how things have been changing of late with the new therapies coming into the market. So clinical classification now also talks about not only congestion but also hypoperfusion of the peripheries. And based on the hypoperfusion, you can decide and the congestion whether the patient is warm and dry, warm and wet, cold and dry, or cold and wet. So a patient who's cold and wet is basically somebody whose perfusion is proper but is extremely congested. Compare this with somebody who's hypoperfused and not having good, is decongested. The patient is warm and dry. So warm and wet would hence mean hypoperfusion with congestion, while a cold and dry would mean good perfusion with congestion. And the features of hypoperfusion hence would be cold sweated extremities, oliguria, mental confusion, dizziness, and neuropulse pressure, while congested can be looked at in terms of presence of pulmonary congestion, PND, peripheral edema, JVP elevation, congestive cardiomegaly or hepatomegaly, or hepatojugular reflex or gut ascites, etc. Now the algorithm of heart failure management in patients with reduced ejection fraction talks about whether it's an acute heart failure or not. If that's an acute heart failure case, you need to do a basic baseline hemodynamic assessment and you have to look for congestion. 95% of the patients will in acute heart failure be wet patients. That means they are congested, and hence we have to then assess whether they are having good peripheral perfusion or not. If they have good peripheral perfusion, these are wet and warm patients, and typically they have elevated or normal systemic blood pressure. Hence, these patients, based on the vascular type of fluid redistribution, hypertension, if that's predominating, you would be giving them diuretics and vasodilator, while those with cardiac type fluid congestion and accumulation, you will have to give diuretics, vasodilator, and ultrafiltration may be also a good choice. If the patient is not having peripheral perfusion good, and then you look whether this patient is now actually falling into wet and cold type of hypoperfusion with blood pressure less than 90, then inotropic support is required, which would be assisted along with the diuretics, and also you might have to consider mechanical circulatory support in these patients. If, however, the blood pressure is normal, then you can still go ahead with the dilators and diuretics. In patients who are dry and cold and hypoperfused and hypovolemic, you must consider fluid challenge as the next modality of treatment. Heart failure is now classified as heart failure with reduced ejection fraction are those patients who have all the symptoms and signs with ejection fraction less than 40%, while those with have EF more than 50% or equal to it with symptoms with elevated biomarkers of NT-proBNP, at least an additional criteria of relevant structural or diastolic dysfunction would fall into heart failure with preserved ejection fraction. Patients with EF between 40 to 50% hence are called into mid-range ejection fraction. There is an additional term called as improved ejection fraction. These are the patients whose ejection fraction was previously low, has now increased and improved to become in the range which is either mid-range or preserved. American Cardiology Society, ACC and AHA also talk about various stages, the stage A being at risk of heart failure and no structural heart disease. So patients like diabetes and hypertension are all stage A hypertension even though they don't have any structural abnormality at heart. Stage B are patients who have structural heart disease but they don't have symptoms. So patient like ejection fraction of 40-45% have some myocardial dysfunction but they are still asymptomatic would fall into this stage. Stable heart disease with symptoms are stage C, and patients with refractory heart failure would be stage D. When you look at the prevalence of these various stages, you would realize that there is a huge population burden at risk, which is 50 to 60 million across the world, amounting to 22% in Olmsted's 45% plus years of series. Only 1/3 of the patients are actually normal, 2/3 of the population above 45 falls into this category. Patients of asymptomatic around stage B account for 34%, 12% are stage C, and 0.2, which is 0.2 million of patients are refractory heart failure stage D. Various treatment modalities have been evaluated both in reduced ejection fraction and preserved ejection fraction, and this slide shows you various trials that have been done for preserved ejection fraction. Beta blockers, ACE, ARB, digitalis have been proven and been important therapy in reduced ejection fraction. You also can add this ARNI to it. We also know that MRA, aldosterone antagonists, are both indicated to some extent both in preserved and reduced ejection fraction. However, PD5 inhibitors could not be established either in preserved or reduced ejection fraction. Endothelin antagonists and ARNI have been studied in both. Paramount and Paragon give some indication in preserved ejection fraction, but they are still class 2 and not so strongly advocated. So CRT and ICD are only for reduced ejection fraction, and the evidence for vagal stimulation is also now emerging. Baroreceptor like barostim neotherapy are now indicated in patients with reduced ejection fraction, is now FDA approved. Hemodynamic monitoring and cardiac rehab are important therapies that are evaluated both in reduced and preserved ejection fraction. So when you look at the patients with stage C and D, when you have a patient who's got heart failure with reduced ejection fraction, you would put them on a guideline-directed therapy, which is ACE-ARB or ARNI, with guideline-directed beta blockers and diuretic as indicated. Once the patient has specific clinical scenario, like patient who's got creatinine clearance more than 30 but potassium less than 5, you would choose aldosterone antagonist, while patients who are class 2 to 3 and have adequate BP and are on ACE or ARB and there is no contraindication, you should step them up to ARNI. So this would require discontinuation of ACE-ARB and you have to initiate ARNI. Patients who are class 3, 4 and black patients, you can consider hydralazine and nitrates. Patients with EF less than 35, with a caveat that if the survival is not more than 1 year and more than 40 years of post-MI, in those patients only you could choose an ICD. In patients with wide QRS complex with LBBB duration more than 150 milliseconds and functional class 2 to 4 with EF less than 35, CRTD or CRT is also indicated. In patients whose heart rate is more than 70 on maximally tolerated beta blocker and are in sinus rhythm, can be thought of to be considered on ivabradine, but this is a class 2A indication. The rest all other therapies are class 1. Refractory heart failure of class 3, 4 or symptoms, if they are improved, can further be chosen according to their needs for palliative care, transplant, LVAD and investigational therapies. There are various biomarkers in heart failure. Inflammation can be assessed by CRP, tumor necrosis factor, APO1, interleukin 1, 6 and 18, which are biomarkers in this category to help in elucidating pathogenesis of heart failure. Oxidative stress can be measured by oxidized LDL, peroxidase, urinary biopyrins, urinary plasma isoprostanes and plasma malondiamide. Extracellular matrix remodeling is assessed by matrix metalloproteinases, tissue inhibitors of the same, and collagen propeptides, propeptide collagen type 1 and plasma procollagen type 3. So beyond these heart failure markers, there are some cutoffs for diagnosis, which is we should know in day-to-day practice. The NT-proBNP cutoff is more than 900 is definitely diagnosis, less than 300 excludes. In between is the gray zone. BNP same way, more than 100 is definitive, less than 30 to 50 excludes heart failure. MR-Pro-ANA is the other mid-regional pre-adrenomedulin, which is 127 and 57 for the respective values. Prognostic values are provided also by chromoganin, galectin-3, osteoprotegerin, adiponectin, growth differential factor 15 and soluble concentration of ST2. The existing therapies hence for symptomatic benefits include vasodilators, inotropes and diuretics, but survival benefits are now proven for ACE inhibitors, ARB, beta blockers, spironolactone, hydralazine nitrates, and you can add now 2 more drugs, which is SGLT2 and also ARNI. So the novel agents that have now decreasing the cardiac workload include natriuretic peptide like nasritide, ureatide and carbitide, normal RAS blockades, which is the ARNI, vasopactative peptides like omnapratylate, which have now been proven to be not of great benefit, and same is the case with direct renin inhibitor like aniliscarin. Vasodilator like relaxin can also be used in acute therapies. Vasopressin antagonist like tolvaptan is preferred in patients with hyponatremia. Bosentan and other endothelin antagonist and soluble guanide cyclase stimulator like sinaciguate, and then now recently vericiguat, which has been evaluated, and Victoria trial has been shown to reduce heart failure hospitalization. Drugs that increase cardiac contractility include omective mecarbil, which is cardiac myosin activator, sodium potassium ATPase inhibitor, which is isotaroxam, and marinodin receptor stabilizers and SERCA-active activators are also being evaluated in the therapy. Calcium sensitizers like levosimendan and anoximon are used in acute heart failure in patients with good blood pressure in trying to improve the cardiac output. Miscellaneous drugs acting through novel pathways include rolophilin, also CPT1 inhibitors, ivabradine, And now potassium absorbers like patiromer and zirconium cyclosilate have also been given in patients with heart failure with hyperkalemia. The vericiguat, which is an oral cyclic guanine stimulator, has now been studied in Victoria trial, and it has shown to improve not only hemodynamics, but also it is not known to cause much of hypotension in the trial. It also reduces need for heart failure hospitalization. Omective mecarbil increases myocardial contractility, and it increases the transition from weakly bound to strongly bound state, hence initiating the power stroke of the myocyte. Increasing the systolic ejection time without altering the rate of LV pressure gradient leads to increased stroke volume and cardiac output. Istaroxamine, which is basically stimulating the NAK-ATPase pathway, enhances the activity of SRCA2. SGLT2 inhibitors, which is Cana, DAPA and empagliflozin with ertugliflozin, all have been shown to reduce heart failure hospitalization. The strongest data, however, exists in the DAPA-HF trial, where dapagliflozin was evaluated, and it showed that DAPA in primary outcome of cardiovascular death, heart failure hospitalization or urgent heart failure visit was reduced significantly in absolute number by 5%, which is like net number to treat being just 20. CV death also there was reduction with almost 18% reduction, and also there was renal preservation with a good trend of renal function preservation in the long term. So among patients with symptomatic heart failure with reduced ejection fraction, dapagliflozin is to be given to reduce cardiovascular death and heart failure events, irrespective whether patient is diabetic or non-diabetic. So usual care versus hemodynamic monitoring has now been proposed. Hemodynamic monitoring would include weight, symptom and hemodynamic assessment by a loop or the implantable wear devices. This leads to potentially less frequent need for physical exam and echo, with opportunity for remote visits, and office visits only can be needed as and when the alarm goes on. Proactive, guided and personalized adjustment of therapy hence can be adjusted in these patients. So this is how the device works. It's a hemodynamic data which is analyzed by the implanted network device, and the data is transmitted to the clinician, who then can communicate the treatment plan on cell phone or a device analyzer, and there is a change of therapy which the patient can go at home. In a champion trial which randomized 550 patients, this wireless monitoring system of PA pressure in addition to the standard care group found that there was significantly fewer heart failure hospitalization in treatment group. The result of champion trial led to the FDA approval of implanted hemodynamic monitoring system. The molecular target for the gene therapy have also been the SRCA2A, SDF1, ADCY6, S100A1, C-terminal fragment of beta-adrenergic receptor kinase, and parvalbumin. The limitation of gene therapy, however, is that despite the optimizing the design, the vector still demonstrates some immunogenicity, and this can lead to decreased transcription, limited biologic effect, and development of myocarditis. The baroreceptor or barostim therapy is a neuromodulation therapy. It's designed to trigger the body's natural reflex to regulate blood pressure and prevent the progression of heart failure. The long-standing implant system Barostim Neo, which is customized to each patient's individualized therapy, is developed and it's now approved therapy in heart failure. It's an implantable pulse generator which is operated, and the device is put like a pacemaker, and the wire is connected to the vagal nerve as demonstrated in the picture. So this is a subcutaneous sinus lead of 2 mm electrode attached to the carotid artery and connected to the implanted pulse generator, which is inserted under the skin below the collarbone, delivering the electrical stimulus through the lead position in the carotid adjacent sinus. The wireless programmer system enables the clinician to customize therapy. The unique on and off capability can promote the observation of differences, making the blood pressure and other hemodynamic parameters. BEAT-HF trial was the one that was evaluated, and FDA approved the adults for refractory heart failure who are unsuitable for devices like CRT. So patients with narrow QRS complex are the one who actually are recommended now with refractory heart failure to be chosen this therapy. So BAT therapy is though to counter neurohormonal effects of heart failure, ventricular remodeling by inhibiting the sympathetic and also enhancing the parasympathetic activity. So this brings us to the end of the recent advances that are there in heart failure. To summarize, the important therapies are beta blocker, ACE-ARB or ARNI, mineralocorticoid receptor antagonist, which is spironolactone or eplerenone, addition of therapies like SGLT2 inhibitor. Now also you have one more pillar in form of the treatment of the cause, so SGLT2 therapy. You have also therapies like IV FCM, which is ferrium carboxymaltose, for the correction of iron deficiency even without anemia. And now we have new drug, vericiguat, which is a cyclic GMP analog, and it's a good therapy in patients with heart failure. So this talk summarizes all the important therapies that are there in heart failure and what is emerging for management of refractory heart failure in future before the patient is suitable for heart transplant. Thank you very much. Stay connected. Bye-bye.